What are these needles? These needles are spinal needles or lumbar puncture needles. And what are its uses or indications? It has got diagnostic uses and therapeutic uses. Diagnosis of infections, inflammations, and neoplasias. It can be used. Where to puncture in lumbar puncture? The spinal cord ends at the level of L1. Obviously, puncturing at this height will produce injury to the spinal cord. The conventional site is between L3 and L4 spine, or between L4 and L5, which are considered to be safe places. Under the infections, we have different types of meningitis: bacterial, viral, fungal. We have encephalitis, amoebic, or parasitic infections. And neurosyphilis is also very important indications for doing lumbar puncture and analysis of CSF fluid. Inflammatory diseases, mainly demyelinating diseases, particularly multiple sclerosis, Guillain-Barré syndrome, autoimmune encephalitis, and sarcoidosis are other indications. Whenever the imaging doesn't confirm the diagnosis of subarachnoid hemorrhage, but he still suspects subarachnoid hemorrhage, lumbar puncture is indicated. Diagnosis and treatment of normal pressure hydrocephalus, lumbar puncture has to be done. To relieve and diagnose intracranial hypertension of benign nature, repeated lumbar punctures may be done. And diagnosis of calcium-attenuated meningitis also, we do lumbar puncture or spinal fluid study. What are the therapeutic indications for lumbar puncture? It can be done in case of normal pressure hydrocephalus to diagnose it and also treat it. Removing large amounts of CSF, and if the patient improves, that's indication for surgical treatment. In the treatment of different types of cancers, like acute lymphatic leukemia, lymphoma, and so on, methotrexate and other drugs are commonly given. Also, in hospitals, during anesthesia, sometimes this needle is used to give spinal anesthesia. What are the contraindications for doing lumbar puncture? Actually, there is no absolute contraindication. There are relative contraindications, but like local infections, when you cannot insert the needle and you go for cysternal puncture. If there are deformities locally, you cannot be successful in doing lumbar puncture. If there is raised intracranial pressure, and still if you want to study the CSF, as in case of meningitis, you have to go for a guarded LP where you don't remove the stellate completely, but gradually withdraw and you get the adequate fluid for study. Similarly, if there's profuse bleeding, it's also a relative contraindication. What are the prerequisites before we perform lumbar puncture? It has to be absolutely aseptic precaution, otherwise we induce iatrogenic meningitis. We have to check the fundus and rule out papilledema. If fundus cannot be seen, then you have to go for imaging and then rule out possible intracranial tumor before you go for a lumbar puncture. Imaging is done if there is necessity, and then you can proceed with the lumbar puncture. Guarded LP is done in selected cases. There are a few complications for lumbar puncture, namely coning. Coning is defined as movement of structures of one compartment to another compartment. For example, across falx cerebri, one part of the brain may cone to other side. Again, through the tendorum cerebelli, you can have coning. If you don't take proper precautions, you can induce septic meningitis. Local bleeding is another complication. Post-lumbar puncture headache is a very common complication. If you inadvertently puncture a root, you may have radicular pain. Commonly, when we do lumbar puncture, we use a spinal needle, which is called a stillet. If you don't use stillet, if you just puncture the ordinary needle, a part of the skin may go in and it can lead on to subsequent epidermoid cyst formation. How to prevent post-lumbar puncture headache? There are effective strategies and strategies which are used in the yesteryears is found to be ineffective now. The common strategies employed are use a small diameter needle, use a traumatic needle, and replace the stellate before removal of needle. Insertion of needle with bevel oriented in a cephalad to caudal direction when using standard needle. The strategies which were employed earlier but found to be ineffective are bed rest, supplemental fluids, taking minimal amount of spinal fluid, and immediate mobilization following lumbar puncture. They are found to be ineffective. How to identify the spinal needle? They are very thin and they are very long. Two things. 3. It has got a stillet. A needle with a stillet. Thin, long. And there are different colors as you can see. Each color represents a particular gauge. 19, 20, 21, 22. Like that it goes. Different gauges are there. How to plan lumbar puncture if the patient is already on anticoagulants. The patient is on unfractionated heparin. You just wait for 2 to 4 hours and you can proceed. With low molecular weight heparin, you wait 12 to 24 hours time. Warfarin, the effectiveness of warfarin has to be nullified. It may take 5 to 7 days, and then try to do other measures like administration of vitamin K. Newer anticoagulants, you have to wait for 72 hours. If it is subcutaneous heparin, less than 10,000 units, do not wait, you can proceed normally. And there is no contraindication if the patient is on antiplatelet drugs. And after the lumbar puncture, how and when to restart anticoagulants. That is not yet definite. Each individual has to be assessed on its own merit.